In the spirit of disruption, we've all been talking about these payment models and investment, and yet we've got a challenge with the underlying apparatus of these models. And I'd like to welcome Bob Berenson from the Urban Institute and Darilyn Moyer from the American College of Physicians. They've got a challenge to put on the table for us to be thinking about in the year ahead, and then we will wrap. And they're going to do it in just a couple of minutes. And this is off script. It's not in your agenda. So
as I was listening to the uplifting stories and the appeal to new payment models, my 50 years DC experience came through, which is a little more cynical. For those who don't know me, I've practiced internal medicine, primary care in DC. I've been in and out of government, and I'm currently a fellow at the Urban Institute, and I work, amongst other things, on payment reform, especially for primary care, and feel strongly that the National Academy of Medicine's three-point plan, which is to move to a hybrid payment model, part population-based, part fee-for-service, is the right way to go, and have written about the current obstacles to that and how to try to overcome those obstacles. Number two, to increase the total compensation to primary care substantially, because expecting better results with inadequate payment isn't going to work. So support to do things like supporting teams and things like that. And then the National Academy report got something very right, which is often ignored, which is to fix the distortions in the Medicare physician fee schedule. And I wanted to come up to just give you a couple of examples for a couple of purposes. One, so you have them at the ready if you're talking to a legislator or somebody else about the distortions in the fee schedule. That's what can pay for the 40 or 50% increase to primary care are the overpayments that are undeserved in the fee schedule, but withstand change. And that's where my DC experience, it's about an inside game of sort of power politics. You've been talking about sort of an outside game of building the sort of moral and ethical case and policy case for more primary care, but I'm now talking about just in the trenches political warfare to some extent. So I want to give you just a couple of examples, and I hope you might use these, or actually I want to generate some anger in some of you, especially some of you who are clinicians and feel you're underpaid. In your evidence document that was put together, which is very good, it uses a figure that the percentage of total health spend for primary care has actually been dropping and is now approaching, going down to 4%. In Medicare, it's less. Medicare people get more surgeries and more nursing homes and things like that. In the work I did about 5 years ago, it was about 3% of total. Sorry about that. Medicare spends 6%. I'll just use this one. 6% goes to dermatologists. So we are talking about paying primary care docs or clinicians, because that includes nurse practitioners and PAs, and it's internal medicine, family practice, geriatricians, and the small amount of pediatrics in Medicare. Half of what we pay for dermatologists. And how does that happen? Has anybody in this room either administered or been a patient who's had a wart frozen with liquid nitrogen? You know what I'm talking about? Yeah, I'm getting a lot of nods. How long does it take? Would somebody just tell me how much they think long it sort of took? What's that? 10 seconds. Well, yeah, 10 seconds, but there's some time to go to the shelf to pick up the canister, right? Let's say a minute, okay? The fee schedule assumes that it takes 23 minutes for a dermatologist to go to the shelf, pick up the canister, which, costs, is a one-time expenditure. Liquid nitrogen is not particularly expensive, and to administer it. If you read the description that the RUC, the Relative Value Update Committee, uses, it describes things like giving anesthesia to the ward before administration, dressing the ward after the administration. It's all just made up, okay? I'm going to be wrapping up in 30 seconds. The point is, and I'll go to another example, again, dermatology. We could pay, in fact, for the increase in primary care just from dermatology over payment. Actinic keratoses, I've got a bunch of them. They're non-cancerous lesions that get frozen. The fee for paying for freezing 15 or more actinic keratoses, which might take 3 minutes, is $172. That's the national number. The payment for a level 5 office visit, 40 minutes, with a patient with usually multiple chronic conditions requiring face-to-face time for 40 minutes is $180, virtually the same. That's what we've got going on here. And it takes some political action in addition to the more lofty endorsements of the need for primary care. And that's where Darilyn comes in to talk about what's going to happen on that front.
Thank you for those. I'll be very quick because I'm the only person standing between you and the reception at 6. So I'm an internal medicine and infectious diseases specialist who has spent her life pretty much caring for people living with HIV, and I still see patients. I'm the EVP and CEO of American College of Physicians. ACP has the largest delegation in the AMA House of Delegates, with I think 36 delegates now. And we have been looking at the issues around the RUC because we're a big tent at ACP. We've got general internal medicine outpatient specialists practicing primary care like I do. We've got hospital medicine. We've got internal medicine subspecialists. But we know without strong foundational primary care, the rest of the environment just doesn't work. And so ACP worked together with AAFP, with the Renal Physicians of America, with the Florida and Oregon Medical Associations, and with AMDA, which is the Post-Acute and Long-Term Care Association. And we're supported by some folks in the room, Society of General Internal Medicine, and some other folks. And we brought a resolution to the House of Delegates last weekend to call for modernization, the processes, methodology, data collection, and transparency around the RUC. This really aligns with CMS's call on their proposed rule around the RUC. And I'm very happy to report that we got the best outcome possible. The resolution was referred for study and report out, and that really is the best possible solution there. But we're not done. We're just getting started. And to answer what Mayor Ingraham said, I believe, and I think we all believe, and I know that we can all do this together. And I just want to thank you for everything you are doing for patients at every turn, whether you're seeing patients in your practices, you're helping to create policies and systems to get rid of the structural and systemic barriers and to make people understand that primary care is foundational. It does lead to better health now and for later as well. So thank you all for everything that you do, and we're really excited about this news because we're finally starting to see the needle move, but it's going to take a big effort, a big lift by all of us to make this happen. So thank you, and I'll invite Ann Greiner back.
So as you can see, there's a lot of work to do, and we know that we can get it done if we work together. We've got to work on many different levels, the inside game, the outside game, the upside down game. There's a lot of games we got to work on. Thank you all for being here this afternoon, for all of your contributions, your storytelling. We look forward to your essays. We hope that you'll join us this evening. We're going to be recognizing other major primary care champions in our midst, and we just so appreciate all of your contributions, and we look forward to our work ahead. So, thank you.